is uh, look for any nodularity if it is single or multiple. Look for if this is a invasive tumor or a follicular nodular disease. If it is single nodular, we have to look for whether it is what kind of pattern it is and whether it is capsulated or not. So papillary patterns, so look for papillary carcinoma, nuclear features. Cystic, it could be benign cyst. So what kind of lining, what kind of tissue you see in the wall. Then follicular pattern, medullary, we have nesting pattern, high-grade patterns where you look for mitosis, anaplasia, necrosis and all. And then there are some other cases. So when you look at the capsule, if you find capsule, look for capsular invasion and vascular invasion, if any. If you understand this this type of approach to the diagnosis, let's start with the first case, which is a 62-year-old female presented with neck swelling for last 2 years, and on right side neck swelling was there, which used to move with deglutition. USG neck showed right thyroid lobe enlarged with multiple nodules. FNAC was Bethesda category 3, and then right hemithyroidectomy was performed after correlation with radiology and clinical findings. So who wants to take this case? Or should I just arbitrarily call someone?
Ma'am, I will take this case.
Manasi.
Yes, ma'am.
Okay, go ahead. What do you see here?
Ma'am, there is this is an section study. This shows thyroid tissue showing nodules, and it is well capsulated. Fibrous capsule can be seen, and multiple follicles of varying sizes can be seen.
What do you see here?
Calcification can be noted, ma'am.
So before we go ahead, I just want to ask you, Mansi, or anyone else, what do you mean by capsule? What when you say capsule, what are you looking at? A thyroid capsule or capsule of the nodule? These are two different things. You can have a nodule within the thyroid which is capsulated. So when you are saying here it is capsulated, are you looking at the thyroid capsule? Do you see any perfectly nodular lesion with complete capsule around it? Anyone
Yes,
wants
ma'am.
to volunteer?
No,
You
ma'am.
see that?
Architect.
Yes, anyone else? Any of the Apurvas, Bhavesh?
Ma'am, the lesion is diffuse, ma'am, in nature. There is no such capsule within the thyroid itself. It is the capsule of the thyroid gland that we
I
can
agree
see in
with
this
you.
section.
So we do have some fibrous band which is dividing the thyroid parenchyma into multiple nodules, right? Okay, go
Yes,
ahead. Mansi or Apurva, any one of you can go ahead with the rest of the. So one thing is clear here. We don't have a capsulated single nodule. We are looking at multiple nodules. Am I right?
Yes,
Okay,
ma'am.
yes, ma'am.
go ahead.
Ma'am, follicles of varying sizes can be seen, which are filled with colloid.
Okay.
Ma'am, mm, ma'am, follicular hyperplasia and adenomatous change can be seen.
Mm-hmm. At higher magnification, what do you want to see and to look for?
Lining.
Lines. Lining
Cells.
everywhere.
Lining the follicles.
Yes, ma'am.
So these are what
cuboidal.
type of cells are these?
Ma'am,
Cuboidal.
Cuboidal cells.
follicular cells.
Follicular cells are there. Do you want
Yes.
to comment on these follicular cells? When you look at the lining of follicles, what do you look for? They are follicular cells. That's it? Or anything
ma'am.
else you want to look for?
Ma'am, there is
Follicles cells
oncocytic
contain
change in this.
the nuclear features of the.
Okay, somebody said about oncocytic change. Okay. So that I agree, there is marked oncocytic change. Okay, nuclear features. What nuclear features you are going to look for? Apurva Mathur, you said, right?
So, ma'am, eosinophilic cytoplasm is there, nucleus is prominent.
That is for oncocytic change. When you look for nuclear features, what nuclear features you are going to look for? What are you trying to exclude or trying to diagnose here?
Exclude papillary thyroid carcinoma nuclear features.
So
PT.
papillary carcinoma nuclear features, what are they?
Nuclear clearing,
Ma'am, elongation, overlapping.
nuclear overriding.
One person at a time. Somebody can take a lead.
Ma'am,
Nuclear
change in
clearing?
size and shape, like nuclear elongation, nuclear overlapping, overcrowding, then membrane irregularities, like pseudo inclusions, nuclear grooving, and ma'am, chromatin, clear optical chromatin,
That's called as?
orphanania.
Okay. Fine. So do you see them here?
No, ma'am.
No, ma'am. No, ma'am. No, ma'am.
So you have seen the WSI, you have seen the PPT. Based on this, what is your diagnosis? You know the history, right? History is enlarged thyroid lobe. And I think the duration is longer. Like, what do you see in history? What is the
Ma'am,
age of the
long-standing.
patient? It is a long-standing one. There is no rapid
Multinodular.
increase in size. Okay, multinodular on USG. Now we are not going to discuss details of Bethesda system here, but when it is Bethesda 3, any idea what is the next management? What is the management there? If we report as a repeat FNAC or
molecular testing or lobectomy.
Ancillary techniques.
ancillary techniques may or may not be available everywhere. But if there is repeat testing, if shows same thing, what will you suggest? Or what the surgeon would like to do?
Lobectomy.
It's every time lobectomy? When is lobectomy done? I think Dr. Shiva will give us more insight to this later. But it has to, like, we have to look at the clinical and radiological picture. And then only lobectomy will be decided whether to do it or not. Now, in this case, this was a large lobe and it was removed, nodularity. So, what is your diagnosis in this case? Tell me.
Multinodular goiter with adenomatous change.
Adenomatous change. Any differences? Anybody wants to disagree with diagnosis or everybody agrees with this? Yes, Bhavesh, Kalyani.
I agree with it, ma'am.
Okay, who else is there? Kalyani, Kajal.
And I feel it is multinodular goiter with degenerative changes because calcification, fibrosis, and hemorrhage is there, and oncocytic changes.
Exactly.
So
So
it is
I agree with
nodular
you.
colloid goiter with degenerative or secondary changes.
Excellent. So we have this follicular nodular disease or multinodular goiter with a prominent oncocytic change. So they are calling this as a thyroid follicular nodular disease nowadays. Anybody is aware of recent WHO 2022 classification in thyroid? Any one of you have gone through it?
Yes, ma'am.
You know it, Kalyani?
Yes, ma'am.
So is this included in recent classification?
Recent classification, it comes under benign follicular disease.
Right,
Like benign
benign
follicular
follicular
nodular
derived.
disease.
So benign follicular cell derived neoplasms and thyroid
Under
follicular
that,
nodular disease is first time included in the classification which was never included before. Is that
yes,
clear
ma'am.
to you?
Yes,
So this
ma'am.
is one of the commonest cases that we come across in our practice, right? And whenever you come look at these cases, all we have to make sure that you are not missing any focus of carcinoma. And for that, you have to look for all the patterns, capsules, capsular invasion, vascular invasion, and the morphology of the cells. Is that clear to you?
Yes, ma'am.
Do you have any questions in this case?
No.
Okay, should we go with go ahead with the next case?
Yes, ma'am.
I want to comment.
Yeah, Dr. Manjula, can you comment on that?
So the Bethesda has three category.
It is a challenging one. So nowadays, recently the artificial intelligence has had some role in the reporting for reporting for the lesion. Though there are some studies are going on, so that have some role. And as you said, it is in 2022. It is a newly introduced because this enigmatic criteria for the diagnosis, because it is whether it is a follicular neoplasm, follicular adenoma, or adenoma plus hyperplasia, or the hyperplastic nodule. So it is better to have the term like WHO 2022, follicular nodular lesion. So because unless and until we can go do the molecular marker, of course, we can say it is an adenoma we can diagnose. But only with histology, it is difficult to give the proper diagnosis, and it is not coded for that reason. Okay.
Thank you, Dr. Manjula.
So now,
And
so now we can go to the thyroid.
if there are no questions, can we go ahead with the next case?
Asabri.
One of the chat.
Oh, sorry, Asabri. What I wanted to ask Dr. Shiva, I hope I can call you Shiv Kumar. Are you familiar with this term, or most people who deal with thyroid disease, are they familiar with this term, follicular nodular disease? Or are we pathologists now just introducing terms where multinodular goiter was a good term before?
Yeah, so this is a new term. Yes, I'm not sure if everybody would be well versed with this WHO 2022 the new classification that has come up with. So I would say that the large majority of the surgeons would probably not be familiar with this. That's what I would say as of today. But maybe, I think even it'll be difficult for them to get familiarized with this term. I think they'll be referring, they'll be going back to multinodular goiter more than this.
Yeah, that's something that I would like to make a mention of. We are all enamored of new classifications, new terms, etc. But I think that we need to understand something, and that's exactly what Dr. Shiv Kumar said, and that is that we have to use terms that are understood by our clinical colleagues. And so if we are going to use or introduce something new, a synonym should be used, along with it, so that you educate the, surgeons or those who are going to use this or understand this terminology, and not just start using terms which the treating clinicians do not understand. I don't know if you agree with me, Asavari and Swapnil.
Yeah, we do agree with you, ma'am. So every time new classification is there, we always have some new entities. And initially we start giving although we start giving those diagnoses, there has to be some comment. What was it called earlier, or how it was addressed earlier?
Yeah, that's one thing. But I'll tell you what the worth of this follicular nodular disease actually is. If anybody was familiar with follicular adenoma in the previous classifications, the definition was that there could be just one follicular. It was a solitary disease. And it was very obvious, and it was obvious to most of us who practice in areas of, where there is still goitrous disease, that you had a multinodular goiter, and in a multinodular goiter, you could have 3 or 4 or even more well encapsulated, completely encapsulated lesions, which otherwise would fit the definition of a follicular adenoma. So now what do? Do you call them multiple follicular adenomas in a multinodular goiter? And I think that this thyroid follicular nodular disease has come about as a way of overcoming this, I thought, ridiculous definition of just one adenoma in the thyroid. And it was devised in the West, where they didn't have much goitrous disease. In the sub-Himalayan areas and in many parts of our country, we have a lot of goitrous disease, and it hasn't disappeared despite the iodination of salt and all that sort of thing. Anyway, Asavari, you can put up your definition of thyroid follicular nodular disease.
It's similar to what we said just now. It can be called multinodular goiter, it can be called multinodular thyroid hyperplasia or adenomatous nodule. And basically, they are including it because it shows multiple clonal and non-clonal nodules. Of this is the first time they have included in their classification. Sometimes it can show papillary pattern also. Basically, it's very blunt, no nuclear features of thyroid carcinoma, and there is no invasive growth. I think we can go ahead with the next case. Okay. So this is a 27-year-old female presented with a left neck swelling, noticed 3 months ago, gradually increasing in size. On ultrasound, it was 1.6 centimeter, terads 4, and FNSE was suspicious for follicular neoplasm, Bethesda category 4, and hemithyroidectomy was performed. Okay, who wants to take the lead?
Ma'am.
Yeah.
The section examined shows an encapsulated nodule containing follicles of varying sizes, macro, micro follicular pattern. You can see.
So
most of the macro follicles are filled with colloid.
So we have a capsule here. Once we see the capsule, what are you going to look for?
Invasion.
Invasion. There is capsular invasion or vascular invasion.
Did you find anything?
Not here, ma'am.
No?
So one thing
No, ma'am.
before you go ahead is that I'd like to point out is to look at the cellularity of the lesion. Okay, so if you compare it to the cellularity of the previous case, there is a dramatic difference in the cellularity of the lesion. Now, the presence of this kind of cellularity and very closely packed small colloidless follicles at times is something that should point towards you that this is not simply a non-neoplastic lesion. It is likely to be a neoplastic lesion. It is not on the lines of multinodular. So you could have multiple nodules like this, but it's not something that you should consider as a multinodular disease or a follicular nodular disease. So at low magnification itself, to me, this points towards a neoplastic disease with some sort of a capsule around the lesion, and obviously there is a predominant follicular or microfollicular pattern. Okay, then you can actually dip down deeper to look at the capsular invasion and other invasive features that point towards it. Once you have a capsulated single lesion with a follicular pattern with this kind of high cellularity, this is some form of a follicular neoplasm with a capsule. And if you have adequately sampled it, you should be able to comment on whether there is invasive invasion into it or not. And there are a lot of definitions. Like in this focus, you can see that even at this magnification, which is roughly a 10x magnification, you can see that there is something that is jutting out from the capsule. And this is one indicator that there is a capsular invasion. There are many definitions of what is capsular invasion and what is incomplete capsular invasion, what is a questionable capsular invasion, and things like that. And based on those definitions, you have to decide between a range of diagnosis, ranging from widely invasive follicular neoplasms to minimally invasive follicular neoplasms to a follicular tumor of uncertain malignant potential. So it's a spectrum of tumors that have a similar morphology, and once you have decided this at, let's say, 10x or even 20x, and then you finally jump down onto the 40x to look at the nuclear features. just to say whether this is it has papillary nuclear features or no. Does it have increased mitosis, any necrosis that is there in this case? Because the presence of either the papillary nuclear features is going to change your diagnosis. The presence of mitosis, which currently is defined as more than 5 mitosis per 2 millimeter square. 2 millimeter square is roughly 10 high power fields. Okay, this is roughly 10 high power fields. And the so that is the general approach I would take with this kind of a lesion. Start at low magnification. The cellularity tells me it's neoplastic. At low magnification, I can locate the capsule and see that it is complete or incomplete. And if I see a complete capsule, I am now looking for capsular invasion. Again at low magnification or intermediate magnifications, and then only then when I jump into 40x, it's only to look at papillary nuclear features, anaplastic features, as in nuclear anaplasia, not the architectural anaplasia, but nuclear anaplasia, and mitotic figures to rule out high-grade differentiated papillary, high-grade differentiated thyroid carcinomas or some other lesion like that. So, this is my general approach to this kind of a case. Okay. Now, truly speaking, there is no thyroid. The thyroid gland truly does not have any capsule. It is just some condensation of the connective tissue around it, and the capsule that we talk of when in this is actually of the thyroid, whatever lesion that we are looking at. Okay. All right, let's go ahead with this. So in this case, this particular location has this capsular invasion. Okay. And then you would search for vascular invasion. So, and then you would count how many foci of invasion are there. So this is definite capsular invasion, which is going beyond the capsule, almost like a mushrooming kind of a thing with the two capsules at both the sides, and then something jetting out of the capsule. And so this is good enough for a capsular invasion. And if there is no vascular invasion, I would, and no nuclear features of PTC, I would call it invasive, minimally invasive follicular carcinoma. But if on high power, I see papillary thyroid carcinoma features, nuclear features of PTC, then I would call it invasive encapsulated follicular variant of PTC. Okay. So that's the role. Most of these diagnoses are morphology based and not really any other IHC based or any other features.
So now,
so in this case, there are obviously nuclear features of PTC, like the clouding and clearing and irregularity, and I think some grooving as well.
so can you describe that? Who was describing? Apurva?
Yes, ma'am.
What do you see here? What have you noticed all these features?
Yes, ma'am. There's nuclear clearing is there. Then proving is also there, ma'am. In the next slide.
Yeah. So just enumerate all the positive points, what Dr. Swapnil just taught you and what you have noticed in this slide.
And there is nuclear clearing, overcrowding.
And start from the beginning, Apurva. You saw capsulated neoplasm, right?
Yes, ma'am. So encapsulated neoplasm. There is encapsular invasion seen.
Okay. What was the pattern? We found there's this capsulated neoplasm. The tumor is what kind of pattern tumor is showing? What kind of patterns do you know in tumor?
Follicular.
Thyroid tumors, what type of patterns you have seen?
Follicular pattern here.
That's it? In this case, follicular pattern. What other patterns you should? Anyone else? Who else is there?
We can see capillary pattern.
Microfollicular, macrofollicular pattern.
Oh, yeah. So go ahead. What are the patterns?
Ma'am, follicular, microfollicles, macrofollicles, papillary pattern as nests. Then
any other pattern? We are going to look. You have seen those cases. We have shared some of the cases which show all other patterns. What other patterns you see it in thyroid tumors?
Trabecular pattern.
Trabecular, and what else? Do you see solid pattern?
Solid
Do
pattern.
you see
Solid
the ring pattern?
nest.
All cell pattern.
That is different. All cell is different. That's a different subtype. Patterns, we are talking about the arrangement of cells. So commonest is the follicular one, and we are going to look at those cases with follicular pattern, those thyroid tumors with follicular pattern, how to approach to the diagnosis. Okay. So this is what you are looking at, the follicular pattern tumor. Now you tell me the diagnosis.
Follicular variant of parathyroid.
What is it?
It is invasive capsulated.
This even in many
Invasive capsule.
follicular.
Follicular variant of PTC.
That's fine. So what kind of invasion you will call this? Is it a minimal invasion or widely invasive?
Minimal invasion.
Minimal invasion.
So that's right. Invasive encapsulated follicular variant of papillary thyroid carcinoma, right? So whatever Dr. Swapnil told you just now, let's have some quick recap of this. When you're looking at capsulated tumor, Swapnil, you want to go ahead?
Yeah, I mean, this is what we discussed, that once you have decided that this is an invasive encapsulated follicular carcinoma or follicular variant of PTC, you need to subclassify it further as either it is minimally invasive or widely invasive or angio-invasive. Okay, and unlike PTCs, encapsulated FPPTs is actually much closer to follicular neoplasms or follicular carcinomas because they have more of RAS mutations than RAS mutations. Okay, that is how this happens, and most of these tumors don't actually go to the nodes. They behave more like follicular carcinomas, despite the nuclear features of PTC.
So you can see follicular pattern in multiple thyroid lesion and benign thyroid also. And as we said, we have to look for nodularity, capsule, nuclear features and patterns. And follicular pattern can be seen in benign tumors, low risk neoplasms and malignant neoplasms. What we are going to look for is whether it is capsulated or not. Yeah, go ahead.
So before that, I'd like to, when we talk of patterns, there are two things. One is the architectural patterns, and one there is a cell types. So tall cell, columnar cell, hobnail cell, clear cell. These are all cellular features and not architectural patterns. On the other hand, architectural patterns are more like capillary, microfollicular, trabecular, insular, solid, and things like that. So when we talk of patterns, we are talking of architectural patterns and not cell type. Okay. So always make the distinction that architectural patterns you are trying to detect all of that at low magnifications, 4x and 10x. While cell types you might have to go at a more higher magnifications, maybe 20x or so.
Okay.
So there are some synoptic like reporting points that you can at times use. So these are just some pointers towards what all things you should be looking at, so that you don't miss any of them. And based on the findings, you can divide into other things. By definition, the papillary architecture should never be more than 1% of the entire tumor that you see in when you want to call it follicular variant of PTC. The very reason is that a tumor which has more than that much amount of PTC papillary features is more likely to be a classical PTC rather than or something that is closer to follicular neoplasm. Okay, and the one basic thing is that most of the follicular neoplasms, which include the follicular variant of PTC, will have more of vascular invasions and vascular spread rather than lymphatic spread. Unlike classical PTC, which is more of a lymphatic spread than vascular spread, right? So if you see classical PTC, you essentially want to have also the neck node dissection and things like that. But encapsulated follicular variant of PTC or follicular carcinomas, whether invasive, minimally invasive or not, or widely invasive, they are unlikely to have nodal metastasis. This is the diagram that we is classically referred to in multiple books, as well as the CAP protocol for deciding what is a definite capsular invasion. So, so something that has to go, this is obviously an idealized diagram, okay? In real life, you will actually find much more complicated situations, but the general principles remain the same.
So whatever you see, C, D, E, H, these are all examples of capsular invasion. Similarly, for vascular invasion, again, you have to look at the look for the vascular invasion in the capsule or outside the capsule like this. Directly the tumor budding out is not just a vascular invasion. You have to see the endothelial cells with tumor attached to the vascular wall. So, again, just to have a quick recap, we are looking at capsular and vascular invasion plus papillary thyroid carcinoma like nuclear alteration, right? If both are absent, capsular and vascular invasion are absent, PTC absent, like nuclear feature absent, this is called as follicular adenoma. Is that clear to you, right?
Yes.
Now, when we have capsular or vascular invasion and PTC like nuclear alteration, what is it? Refer to this diagram. Look at this. And one person can answer. I want to know whether you are you can see this diagram, this table or not.
Yes.
Yeah, go ahead. This is invasive capsulated follicular variant of PTC, right?
Yes, ma'am.
Yes, ma'am.
So now there are some areas, some cases where you are not sure whether the capsular invasion is definitely present or not, what they call it as questionable. But before we put anything in this category, we have to sample it extensively, take the deeper cuts and make sure that we are not missing a true capsular or vascular invasion. Similarly, you may not be sure about PTC like nuclear features, and there they are putting this cases in well-differentiated tumor of uncertain malignant potential, but certainly nobody likes this diagnosis, definitely not the surgeons. We have to make our extra efforts, take extra efforts to make sure that whether it is fitting in any one of these categories like NIFT-P. What is NIFT-P?
Non-invasive
Follicular
follicular papillary like nuclear.
So we looked at this invasive encapsulated follicular variant of papillary thyroid carcinoma that shows PTC-like nuclear features, right? But that should have capsular or vascular invasion. If it is completely absent, this will be NIFT-P. So it should be clear to every one of you that when you call it NIFT-P, can you diagnose NIFT-P on one or two sections? If you get a case for second opinion, suppose, and we have only two sections available with some capsule, are you going to call it as NIFT-P just because it is not showing any capsular invasion? So definitely we have to make sure that entire tumor capsule is sampled and we don't see any capsular or vascular invasion. Then and then only we are going to call it as NIFT-P. Is that clear to you?
Yes.
Now, capsular vascular invasion present, but PTC-like nuclear features absent. That is going to be
Follicular
carcinoma. So just remember this table very well, and it will be easier for you to diagnose these conditions. Basically, adequate sampling is essential for adequate sampling of thyroid capsule. The capsule of the tumor is essential to make a diagnosis of NIFT-P. And just these are some important features of NIFT-P. I think all of you know that. So, any questions on this case, Dr. Manjula? Would you like to say something?
Yes. So the diagnosis of this case, that was invasive encapsulated follicular variant of papillary. So if you keep in mind in the synoptic approach of reporting, as Dr. Rane has described, it is very easy to diagnose the cases. And he has mentioned another very important point, that is the mutation, race mutation in this case of tumor, this encapsulated tumor. And in case of the NIPT, so this is the WHO has not mentioned the carcinoma, that is the non-invasive follicular tumor with papillary-like nuclear disease, but it is named is not given like carcinoma. So the prognosis is very good of this tumor, and the nomenclature is also very nice without giving the nomenclature of the carcinoma. So this is my point in regarding this case.
Thank you, Dr. Manjula. Can I ask one question,
One
Dr.
last
Shiva?
point. One last point I'd like to make is that by current WHO criteria, we cannot really make a diagnosis of NIFP without molecular studies.
Yeah.
So we need BRAF mutation to be absent in these tumors, without which we cannot really make a diagnosis of NIFP. So even if everything is satisfied, we have extensively sampled the lesion, we can only possibly suggest a diagnosis and then ask for a BRAF mutation study, and only after that is proved to be negative, we can conclude that it is NIFP. The very purpose of this is that that we want to keep this entity as pure as possible, because it has excellent prognosis. It has no need for any node dissection, and there is it's practically the lobectomy is the cure for this particular disease. Okay, so this has to be kept in mind, that we essentially cannot give a diagnosis of NIFP on H&E alone.
Yes, sure. It is a very important point. Yes, we have to go for molecular test also. Yes. Thank you.
Dr. Shiva, you were going to say something. Sorry, you were raising your hand.
Yeah.
Yeah,
I just want to make one point regarding the, so what I've seen over the many data sets that we have looked at of what is the most common, on the thyroid malignant data set that we have, is that after the classic variant, the follicular variant of papillary CA is the most common that we see. And the follicular thyroid carcinoma is very less. And there was a mention made on multiple occasions that the follicular variant, the chances of distal metastasis is more without lymph nodal metastasis, which is not what we actually see. They very much behave like the papillary. Clinically, whatever cases we have operated and we have seen, I'm not talking about the entire spectrum of it. Maybe it might be the case when we look at the entire spectrum, but at least the cases that we have operated and treated, it seems to be following the pattern of the papillary thyroid carcinoma. That is the one point that I just wanted to mention. And also regarding the Bethesda 3 and 4 nodules, it's always a very tough call as to how to treat them. So clinically, if I have a Bethesda 3 nodule, probably we'll repeat an FNAC. If in the first FNAC it comes as Bethesda 3, and if it comes as a Bethesda 3, then I think there are the clinical features, factors, and the radiological factors, especially the ultrasound features of the nodule in question, needs to be considered. We're not going to operate a patient or not operate a patient just because it's Bethesda 3 or 4. Now, that is one of the factors. Now, along with that, what are the other clinical factors? Whether there's any history of, radiation exposure, whether there's any family history, whether it's a male or a female patient, whether the patient is less than 55 or more than 55 years of age, and then the various ultrasound features, the echogenicity, the microcalcification, taller than wider. So there are multiple factors to it. So I would just want to stress upon the fact that yes, you have Bethesda 3 and Bethesda 4, but you're not going to operate or not operate just because whatever the Bethesda category is given. Unless and until it is they say it is a malignancy. Even if it is malignancy, there are various other factors to be considered. So this we need to understand. And also the risk of malignancy in Bethesda 3 and 4 is what's given in literature, may not be the same across institutes. We've seen in our own institute that the risk of malignancy is higher than what is reported in literature. So it may vary across institutes depending on whether it's a tertiary referral center for cancer center, that is. So there are various other factors to it. So the risk of malignancy in general is what is given in literature, but it may vary from institute to institute. So you need to look at it, and then we're not going to operate or not operate just based on Bethesda 3 or 4. There are other factors which I just mentioned will also be looked into very closely before we make that decision. These are the points I wanted to make.
Yes.
Thank you very much,
Thank you,
Dr.
Dr. Shiva.
Shiva.
Savary,
So one
can
thing
I
that
just address one of the question sort of statements that Shiv Kumar just made? Okay, and that is about follicular variant of papillary thyroid carcinoma behaving like a papillary thyroid carcinoma. I think, we have to understand that the case that was just shown by Asaveri is quite different from the diffuse follicular variant of papillary thyroid carcinoma. And I think, Shiv Kumar, if you take the diffuse follicular variant of papillary thyroid carcinoma, which is not this case at all, this is an encapsulated tumor, okay, which has now got invasion of its capsule. That is an extremely rare occurrence. Okay, and I'll just address that. I know that this is for postgraduates, and therefore postgraduates should not get unduly burdened with all kinds of complicated statements. But the diffuse variant of papillary thyroid carcinoma behaves like a papillary thyroid carcinoma with metastasis to lymph nodes and lymphangitic metastasis to the lungs. The encapsulated variant of what we are calling papillary thyroid carcinoma is actually related to NIFTP because it is a RAS, mutated lesion. And it is a complete misnomer that it is called an invasive, follicular variant of papillary thyroid carcinoma. It's a RAS mutated lesion. Why should we call it papillary thyroid carcinoma at all?
Yeah, that's true.
It's a ridiculous, it's a perversity that this name has been given to this lesion. Okay, you have a non-invasive papillary follicular tumor with papillary thyroid nuclei, which is NIFTP. Why don't we call this lesion an invasive follicular tumor with papillary thyroid nuclei? But we don't call it that. Right. Now we are calling it invasive follicular variant of papillary thyroid carcinoma. So that lesion, which Asaveri has just shown, is a rare occurrence, and it's not going to behave like the standard diffuse variant of follicular variant of papillary thyroid carcinoma. I'm just addressing it, not for the postgraduates, please, but for some other people who may be in the audience, and just to address the question that Shiv Kumar just raised. Okay, so we have to separate these two lesions. The encapsulated one, which is related to NIFTP, which is a RAS mutated lesion, and the ones that are diffuse, which are often BRAF. They may be, in children, they may not be BRAF, they may be something else. And it's quite common to see this diffuse follicular variant in kids, where it is very solid and which occurs after radiation therapy. They are not BRAF mutated at all. They are, you have one of the red PTC types of abnormalities in that. But since this is for postgraduates, I'm just going to shut up now.
Thank you, ma'am.
Thank you.
Thank you, Shiva. Shiva also. Yeah, go ahead, please.
Yeah. No, I'm not sure. Again, just out of curiosity, I'm just saying that. So what I just mentioned about the follicular variant of papillary CA that we see in our data set, I'm talking about this diagnosis that we have in the histopathology. Maybe today, if you look at those slides, I'm not sure if you reclassify them differently. But then this is what we have, and maybe it'll be a good idea to just look at that. But since 2012 to 2018, looking at our data set, whatever we have operated, it's a large, so 40 to 50% of the papillary thyroid carcinoma was labeled as follicular variant of papillary thyroid carcinoma.
It is not the encapsulated variant. or if
Yeah, so that's what. So
you have to separate them out.
correct.
And this is
Correct.
beautifully done in many studies. So, you know, I think you should look at it before we start saying that there is a difference between our, you know, sort of population and the population that they have seen in the West.
So,
okay.
So what you're saying, ma'am, is interesting. That it makes me think that probably we have to go back and look into those.
Absolutely, yes, just do that.
See if we want to reclassify them differently. That's what I'm just trying to say.
That's right.
I agree with
So
both
the
of
follicular
you.
variant of PTC is actually a very difficult and confusing terminology over the years. And as ma'am said, there is an invasive follicular variant of PTC, infiltrative follicular, which currently WHO calls as infiltrative follicular variant of PTC. Essentially, it is a PTC with follicular pattern. While the invasive encapsulated follicular variant of PTC is not a PTC, it is more of a follicular.
That's exactly what I was saying,
carcinoma.
and I think that you know, that's what I have against the WHO. They sometimes are so poor in the kind of diagnosis that they make. Sorry, I think
just to conclude, and the other interesting point is that I want to make 60% of these patients have nodal metastasis. Let me tell you that as well. So probably we need to look at FPPTCs that we have labeled them as FPPTC. Maybe there's something else.
So in general, when we say FPPTC, we mean the invasive infiltrative kind of a variant. When we say invasive encapsulated, that's a different entity. Anyway, let's go on to the next case.
Before we go on to the next case, just for the students' sake, let's make it clear for them. When we call it as follicular variant of PTC, make sure you look for capsule. If it is completely capsulated, what we discuss now, which are rare tumors, they are like closer to NIFP, and most of them, they will not be so those will be those invasive or infiltrative. There is echo.
Let everybody mute themselves, please, except for the students. Carry on, Asabari.
Asa, you are muted.
Yeah, because I was trying to unmute myself. Okay. So now I think there's no echo. So let's go to the third case.
Ma'am, there is
I
a
just want to
question
know.
in the chat box related to this
I'm sorry. What's the case question here?
What is the management of follicular variant of papillary thyroid carcinoma, whether it is in lines of follicular carcinoma or in lines of papillary carcinoma?
Shiva, do you want to take that question?
Oh, I think I want to take that question because so there are, as you said, there are two different entities. One is a follicular variant of PTC, which is essentially an infiltrative tumor, is to be treated like a PTC. But when we talk of encapsulated follicular variant of PTC with or without invasion, it is to be treated like a follicular neoplasm.
So, I think it's easier said than done because we don't have these information with an FNAC. Now we have to take this call of how to treat this patient based on the clinical findings, the radiological findings, and the FNA findings that is there. So it's not a simple decision like that. So if a patient comes to me with an FNAC of a Bethesda 4, now I would tend to do a hemithyroidectomy for a Bethesda 4. And then take a call. Now, how I do a hemithyroidectomy, and I would counsel the patient that I'll do a hemithyroidectomy, use frozen, and try to do a total if there are some intraoperative findings that are suspicious, if there are any nodes that I see in the central compartment, and things like that. And if that is the case, I do a total in the same sitting. Or else I do a hemithyroidectomy and I wait for the final histopathology report and then take a call as to whether we need to go back in to do a completion thyroidectomy. That again would then would be based on the ATA, that is the American Thyroid Association risk stratification, which is what we follow, as to whether the patient goes into the low risk, intermediate risk, or high risk. So there are various other things. So it's not as simple as that. the FNA, I get it's Bethesda 4, this would be it. If it is Bethesda 5 or 6, again, it depends on the center that you're in. In TMH, I would be, if it is Bethesda 5, I know for sure it is malignancy. In fact, our Bethesda 4 malignancy rates are much higher. So I would go in thinking that I'm going to do, probably a total thyroidectomy, So it's not, I go with the FPPTC diagnosis is in the final histopathology. I don't have the diagnosis in an FNA, which is what we base our decision to operate and the extent of surgery on that.
Yes, yes. Yeah, I agree to that. And but at this point, we are talking after the
There
hemithyroidectomy
is
kind of a
echo.
decision. Kalyani, can you please mute yourself?
Yes.
Right. So this is obviously not a discussion on the FNA part of it. This is beyond the FNA. This is focusing more on the histology and the final thing. And one point that is probably helpful if there is a multifocal disease or a single nodule kind of a thing. Madam, would you offer a diagnosis of invasive, multifocal, invasive encapsulated FEPTC if it is a multinodular disease or multiple nodules of the same thing? Or would you rather offer it as a infiltrative follicular variant of PTC?
You are asking me or Burgess madam?
Either, madam, either of you, madam.
I think I wouldn't give that, but I would definitely like to hear from Burgess madam.
Sorry, I didn't quite get the question. What were you saying, Swapnil?
If there were multiple nodules with similar invasive encapsulated variant of PTC like features, would you offer a diagnosis of invasive encapsulated follicular variant, or would you say infiltrative multifocal follicular variant of PTC, as in it is a PTC and not a encapsulated tumor?
I think this is a very theoretical discussion, Swapnil. I cannot remember seeing a case like this. If it is specific to some case that you have seen, possibly, but no, I think that I would not give this as multiple invasive, FVPTCs. And I think that invasive FVPTC is of an encapsulated kind. I don't like to give that diagnosis anyway. I'm sometimes forced to give that. But I think it is, if you look carefully enough, you will begin to see papillae in this in this kind of tumor. Theoretically, I have never seen it.
Yes,
have you seen it, Swapnil?
Sometimes the situation arises, but essentially, as you said, most of the time we find enough papillae somewhere or the other to actually call it PTC.
So I
but
think
sometimes
that,
people get confused with that.
Yeah, I would look very carefully for papillae. And this 1% rule is another hoax as far as I'm concerned, because first it was 1%, then it went to no papillae. Now it's back to 1%, and I think that this is quite ridiculous. And that's why now they have come to this conclusion that you must do a BRAF mutation. I think it's ridiculous. Who's going to do BRAF? Okay, I think that you just decide that you should have no papillae at all, and that's the rule that I follow. I mean, irrespective of what the WHO says, but I think Shiv Kumar will agree, and everybody will agree, that today risk-adapted therapy is what surgery or whatever is what we should use, because these lesions are innocuous from the point of view of what they're going to do. They don't kill patients unless they're very large, or somebody is a male or above the age of 55 or something of this sort. So why don't we use common sense and risk adapted treatment rather than get into the convolutions of what this is all about? And that's, I think, what Shiv Kumar was saying, that you use risk adapted decision making for patients who have got solitary nodules in the thyroid. If you have multiple nodules, the question doesn't arise.
Yeah, just on those lines, nowadays, for nodules which are less than 1 centimeter, which is labeled as papillary thyroid carcinoma, there are a lot of evidence wherein based on certain when they satisfy certain criteria, they're also kept under observation. They're not operated as well. So the concept is changing. There's good amount of evidence towards that. So we don't have to operate all thyroid malignancies, especially if it is less than 1 centimeter, no nodes, no distant metastasis, no other features. Like these are incidentally picked up. So just to introduce the students to the fact that there are certain less than 1 centimeter thyroid nodules, if found to be malignant, can be observed in a select group of patients.
Thank you very much, Madam and Dr. Shiva. I think there was very interesting discussion, but this is very important topic even for students and all pathologists, as the treatment can change the way we approach to this follicular and encapsulated neoplasms. Any questions? If not, should we go for the third case? Okay, so this is a 45-year-old male. Okay, there are two questions. I think
there are two questions that have come up now.
I'll answer them on the chat, but we can go on to the next case. I'll answer them on the
I
chat.
think so. We can go ahead with the next case. So it's a 45 years male. There is a history of swelling in neck noticed 6 months ago, increasing in size for last 2 months, and it's a right thyroid swelling, which is 3.8 centimeter and TERADS 5. Bethesda, you have clear diagnosis of papillary thyroid carcinoma, and total thyroidectomy was performed. You must be thinking why I'm giving you this case, but I have some reasons, and just let's go with this case. Who wants to take it now?
Ma'am,
Who have an answer? Who is that?
Ma'am, I'd like to do it.
Bhavesh, you want to do?
Yes,
Go
ma'am.
ahead. What do you see here?
Ma'am, it shows branching papilla with fibrovascular
Can you see
core.
papilla at this magnification, Bhavesh?
No, ma'am.
I'm showing you scanner view. The reason why I'm showing you scanner view, in any thyroid section, when we look at the scanner view, it's just to make sure that what you are looking at, whether it is a nodular region, whether it is a capsulated region, whether you can see any extrathyroidal extension, how many nodules are there, right? So tell me, is it a nodular lesion? Do you see any tumor here?
Yes, ma'am.
It's not a normal thyroid, right?
No, ma'am.
Okay. Do you see a complete capsule to it?
No, ma'am. There is invasion subcompartment.
Okay, fine. So let's go ahead now. We'll look at the. I think I have some problem. Okay. What do you see here? You can describe it.
Ma'am, in this slide or the whole one, ma'am?
Here also, and now you can start describing the tumor.
Ma'am, it shows branching papilla with fibrovascular core. In some areas, the papilla are almost cord-like, and the papilla are lined by tall columnar cells, tumor cells, which have optically clear nuclei and abundant eosinophilic cytoplasm.
Yes. Do you want to call all of these tall cells?
No, ma'am, but majority of them, I would like to say they are tall cells.
What is the definition of tall cell? I mean, there are
the length of the cells are more than 3 times the breadth of the cell.
Okay. So do you see that in everything? In entire section? Yeah, I do agree with you. There are some areas showing tall cell, but there are some other areas as well. What are these areas? What type of cell this is? Anyone else?
Oncocytic cells.
Oncocytic, right?
Yes,
so, in other words, like if you see tall cells, you should not see any other type of cells, or if you say oncocytic cells, you should not see any other type of cells. You can see mixture of all these patterns. Am I right?
Yes.
Yes. Okay, so now You have seen this. This is a papillary pattern, oncocytic and tall cell features, right?
Yes, ma'am.
You agree with me? Okay, what is
Yes,
this?
ma'am.
Yes, ma'am.
What is this?
This is,
What I am showing here?
ma'am, this is
What is this? I'm
extension of the tumor,
The
ma'am.
hole.
right.
Muscle.
So
Extra
you can see
Muscle implant.
it is muscle on
calculate
both
muscle
sides.
Muscle
invasion.
implant.
So that is also important because we have to report if extrathyroidal extension present or absent. If present, whether it is going into muscle or adjacent organs, because that is important for the surgeons. So tell me now, what is your diagnosis?
Ma'am, papillary thyroid carcinoma, tall cell variant and oncocytic variant with extension into muscle, ma'am.
So we said because majority of the tumor was showing oncocytic, now they call it a subtype, not variant. Again, changes in nomenclature, but this was majority of the tumor was showing oncocytic type, and then there were focal tall cell features. So now, this was clear-cut of papillary thyroid carcinoma. Tell me what are the subtypes or variants of papillary thyroid carcinoma? Who can
Ma'am,
enumerate?
we have a classical variant,
Okay.
follicular.
Follicular, we had an extensive discussion right now. Follicular, which is infiltrative or invasive. Am I right? This is not encapsulated. Encapsulated follicular variant is completely different. That is taken out. Okay.
Yes, ma'am.
When we say papillary thyroid carcinoma follicular variant, this is infiltrative or invasive. Okay. What are other variants?
Ma'am, cribriform.
Cribriform is out now. That's a separate entity. What else? Who has not answered so far?
Diffuse sclerosis.
Tall cell variant, columnar variant, hobnail
Okay.
variant, solid variant,
Hobnail
diffuse
variant, clear cell variant.
Hobnail PTC.
I'm sorry.
oncocytic variant.
Okay.
Bottom
Oncocytic. So why we have to specify these variants? Can anybody tell me?
Because the prognosis differs for each.
How does it affect the prognosis? Tell me. Which one of these are good, bad? Any idea?
Tall cell variant has the worst bad prognosis.
What about columnar cell?
Columnar cell has the worst prognosis. Along with that, diffuse sclerosis variant, solid pattern, they have a poor prognosis. And also, whenever there is.
So there are some certain aggressive variants. They are called as aggressive variants of papillary thyroid carcinoma, which include tall cell, columnar cell, hobnail type, diffuse sclerosing type, and all. But one thing you have to remember, when we look at the papillary thyroid carcinoma, just don't stop at whether they are showing columnar patterns, tall cell pattern, or some other follicular variant. One other thing we have to look at is number of mitosis. You have to count number of mitosis, and second is necrosis. Presence of necrosis in any of these variants always denotes a poor prognosis. Is that clear to you? And now they have been separated out and as a separate entity. We are going to see those cases later. Anything else you want to add, Swapnil?
Yeah. So, in PTC, there is this one differentiated PTC, which is essentially a curable disease. Even if the disease is metastatic, there is node mets or even possibly distant mets. Because of radioiodine, most of these patients are practically curable. Okay. The problem is with these other tumors, the aggressive variants, the tall cell variant, the hobnail variant, and then the spindle cell and the other variants. And in addition to what is now called as the high-grade thyroid carcinomas, these tumors do not behave like differentiated PTC. So it is very important as to what you are calling differentiated PTC versus any of the other variants. In general, the definition for calling something a variant is 30% of that pattern. But there is one odd diagnosis where the cutoff is 50%. Okay, so classical PTC can have varied patterns, but as long as the individual cell patterns, the tall cell, the columnar cell, or whatever patterns do not cross 30% of the total tumor that we have examined, the diagnosis can be classic PTC. Although if I see too many of these aggressive patterns, I tend to not call it classic PTC. I tend to just say that this is a PTC and that there are too many aggressive patterns simultaneously present in the tumor, whether even if individually those patterns do not cross 30%. So this is my take on it, that it is important to identify aggressive patterns and be very selective about the differentiated PTC where none of these patterns are present in a predominant way.
So I also agree with Swapnil. We don't have to try to put it in one category always. It is often that we see there are multiple features, like you can have mixture of all these tall cell features, sometimes hobnail, sometimes columnar together. So, and when you see that, most important what we have to look at it is, look for is, sample it extensively, look for any necrosis and look for any mitosis which is going beyond 5 or more per 2 millimeter square according to your, you have to find out the size of your field, and accordingly you have to do that. So roughly 8 to 10 fields. If you are getting it more than 5 mitosis or necrosis, then it is altogether different entity with a poorer prognosis. So make sure that you don't miss these aggressive features in any papillary thyroid carcinoma cases. They are not very common, but they are not so uncommon also. Okay. Any other questions?
Ma'am, there is a question. Will microscopic extrathyroidal extension change the stage?
No, I think Dr. Shiva will agree with that. It should be the macroscopic. Am I right, Shiva?
Yeah, ma'am, you're right. It doesn't change the stage, but then the AJCC staging, if the patient is less than 55, it's only stage 1 or 2, and stage 2 means that there is distant metastasis. And if it is more than 55 is when you have stage 1 to 4. But then we don't follow that as far as the, that is just for prognostication, if at all. Now, if you have to decide what additional treatment you would give the patient after surgery in the presence of even microscopic extrathyroidal extension is, now again, we'll use the risk stratification that I just spoke about earlier, wherein whether the patient will be low, intermediate, or high risk. So with this microscopic ETE, the patient would be, in the intermediate risk group. And in such patients, we would add radioactive iodine as part of the, treatment. After surgery, it would be an adjuvant radioactive iodine ablation for these patients. So that is the difference it makes, actually.
Thank you,
so
Shiva.
we need to understand one thing. If I can just complete, the AJCC risk stratification tells us about the prognosis, the survival, whereas the ATA risk stratification tells us about the risk of recurrence. So we are trying to add radioactive iodine to minimize the recurrence. That's the point here.
Thank you very much. Any other questions? Any comments?
Yes, ma'am. There's one more question. Which is more taller, tall cell or columnar cell?
So the thing is that if you really go by definition, tall cell is like 3 times or more, but I have seen many even well-known pathologists using little bit shorter cells than that, and they have called it tall cell. So it is not the taller or which one is taller. It is the typical morphology. If you look at it, columnar cells, you have some vacuolated cytoplasm or clear cytoplasm. So all morphological features has to be noted. Any other questions?
No, ma'am. That's it.
Any comments, ma'am? Dr. Manjula? Okay. If not, should we go ahead with the next case? This is case 4 now. 66-year-old female, swelling on the right side of the scalp and neck swelling. Now left neck swelling moves with the deglutition while there is right parietal scalp swelling. The ultrasound shows a 4.5 centimeter Terrace 4 tumor in the thyroid, and CCT shows expansive lytic lesion in the skull. FNAC shows FNAC was called Bethesda 4, and parietal lesion biopsy was called metastatic carcinoma of thyroid follicular origin. Total thyroidectomy was performed, and this is what it is. So now, who wants to volunteer for this case? Who else has not?
Ma'am, can I try, ma'am?
Suha?
Yes, ma'am.
Yes, ma'am. Okay, go ahead.
Ma'am, at this power, we can see it's a capsulated lesion with high cellularity. At this lesion, at this power, we can make out only this much. Going to the higher power.
Do you want to say something about this?
Capsule, ma'am. We can see the capsule, and at this power also, we can see the capsule is invaded, ma'am.
Excellent. Okay, it's taking time for me to. Okay, what do you see here?
This is the capsular invasion we can see here.
So you can see the normal thyroid tissue
Normal
here,
thyroid
you can see the
tissue also.
capsule here, and there are multiple foci of capsular invasion, right?
Yes, ma'am.
Okay, what do you see here?
Ma'am, these are the microfollicles, ma'am. The cells are arranged as microfollicles.
Okay. So you looked at the capsule, there is capsular invasion, there is microfollicular pattern. What else you are going to look for now?
For the nuclear features, ma'am, there are no papillary nuclear features, ma'am.
They're not very good though, but maybe somebody may call it, may not call it. I think higher magnification, do I have that? It's just clearing, but not very good okay, papillary features. I agree with you. Okay. But then there is definitely there is a follicular pattern. Do you agree with that, right?
Yes, ma'am. Yes, ma'am.
What else? Now, when you see this, what else you are going to look for?
Ma'am, we have to look for angio invasion cap. Also.
That we'll see. That will if it is there, I'll show you. What about this? I'm pointing out something.
Colloid, the amount of colloid that is present within the follicle.
It's not the colloid. We discussed something. Okay, this is better seen here.
Mitosis.
So, as we were discussing earlier, we have to look for mitosis and necrosis. Am I right?
Yes.
Yes, ma'am.
Do you see in one field how many mitoses are there?
Here three
are there.
So what are you going to call this then? And what is this? The center portion?
Necrosis.
It's necrosis. What do you see here?
This is capsular
invasion.
Capsular and probably one vascular invasion as well.
Vascular invasion.
Vascular invasion is there.
Okay. So now what is your diagnosis? Just summarize. Suha, just summarize all the points and tell me the diagnosis.
Ma'am, capsulated lesion with cells arranged in microfollicles with necrosis, capsular invasion, then angio invasion.
So it's not very well captured. This is like the thyroid. Probably it is entirely replacing the thyroid. But yes, we do see a lot of many foci of invasion. Okay, and there is angio invasion. But what is most important here is
mitotic figures.
Mitotic figures and necrosis and pattern.
Pattern.
What kind of pattern it is? Follicular pattern. So now what? How do you want to classify that?
Ma'am, follicular carcinoma with metastasis.
See, metastasis definitely is there, but do you still want to just stick to follicular carcinoma? We said it is when it is necrosis is there and high number of mitosis.
High grade.
So what is that called as?
Differentiated high grade.
High grade differentiated thyroid carcinoma. See,
Mildly invasive.
So widely invasive follicular carcinoma, that's what earlier it was called, and we used to say there is necrosis and mitosis high. But now these are separated out from other follicular carcinomas because those showing necrosis and mitosis, high number of mitosis more than 5 or equal to 5, they are known to be associated with poorer prognosis. Okay. So now this is called as high grade differentiated thyroid carcinoma, and this is actually, there is this entity has been included in new WHO 2022 classification. Do you know about poorly differentiated thyroid carcinoma?
Yes, ma'am.
Ma'am, in that
What do you see in
mitosis
yeah, go ahead.
mitosis count will be
Brisk
more than
mitotic
3
activity.
More than equal to 3 per 10 high power
per
unit.
What
and ma'am,
else?
necrosis will be there and convoluted nuclei will be seen, and we'll be having
But
solid or
solid
trabecular.
trabecular insular pattern. But there was one important thing is solid trabecular insular pattern, and there should not be any papillary nuclear features, right?
Yes, ma'am.
But now here, what we see here is, in this case, we have follicular pattern. It's not solid trabecular or insular pattern. But we have mitosis and necrosis. Are we going to say that it is not poorly differentiated? Definitely it is associated with poorer prognosis, right? So now this one entity, high-grade follicular cell-derived non-anaplastic thyroid carcinoma, you have to understand this concept behind this. If you take this follicular-derived malignant tumors, all those papillary carcinomas and follicular carcinomas, when you compare with them, the prognosis of these tumors is worse. But when you compare with anaplastic carcinoma, it is still better. So if you really stratify according to risk, all papillary carcinomas and follicular carcinomas of thyroid, they are somewhat better behaving tumors. High-grade follicular derived non-anaplastic carcinomas are intermediate. They do have intermediate type of prognosis, and anaplastic carcinoma will have worse prognosis. Now, in this category, the high-grade follicular cell derived, we have two categories. What was earlier called as poorly differentiated thyroid carcinoma, and today's case, differentiated high-grade thyroid carcinoma. Is that clear to you?
Yes.
And why we are called this, why we are including them? Because by earlier definition, PDTC or poorly differentiated thyroid carcinoma, as you correctly said, it should satisfy all these criteria, right? But sometimes we do get some papillary tumors, follicular tumors, where we have necrosis, where we have high number of mitosis, and they have equally worse prognosis. So they are called as differentiated high-grade thyroid carcinoma. So now our job doesn't stop at diagnosing just follicular carcinoma or papillary carcinoma with its subtypes. We have to always take efforts to look for mitosis and necrosis. Is that clear to you?
Yes, ma'am.
Yes, ma'am.
Any questions on this? Swapnil, you want to say anything? So this is just criteria that have been enumerated in this poorly differentiated thyroid carcinoma. It should not have anaplastic morphology, should not have papillary nuclear features, and as we said, solid trabecular insular pattern with mitosis, necrosis. This is one of our cases just for your um, just to show you that it has mitosis, necrosis, and a solid pattern. And then differentiated high grade, which will have 5 or more mitosis per 2 millimeter square necrosis, but it can show papillary features, nuclear features, it can show follicular morphology. And this is another case where you can see follicular features are there, follicular architecture, necrosis, and mitosis. Another case
So
where you see
I think
tall cell
everything is
morphology and mitosis.
included.
Sorry?
Yes, everything is
Go ahead.
included. Everything you have said, madam. But essential thing is that one has to start with the thought that one is trying to find if there are any aggressive features. You know, the aggressive features can be in the form of mitosis, necrosis. They can be in the form of architectural patterns, the trabecular, the insular, and solid patterns, and or there are cell types, the tall cell, this cell, that cell. And if these aggressive patterns are not there, then you talk of all the differentiated tumors, whether you have got to talk of differentiated PTC, whether you want to talk of encapsulated variants of whatever tumor, or follicular carcinoma differentiated and things like that. So your entire approach has to start from trying to identify these high-grade tumors very accurately and not miss them. Because no matter what the patterns and what the cell type, if you find any of these high-grade features, they have to be pushed into a high-grade thyroid carcinoma or PDTC or anaplastic thyroid carcinoma in that area. Now, most of the anaplastic thyroid carcinomas will not respond to radioiodine as a general rule. And that is also what was expected from PDTC. But I'm sure that there are at least a proportion of cases of so-called PDTC which respond to radioiodine. And we are obviously high-grade thyroid carcinoma is of a new entity, therefore we don't really know what exactly is the response profile to radioiodine. So as a pathologist, it is important to identify high-grade tumors